So today we're going to talk about the respiratory system, and this system is just basically our system that allows us to breathe in and out and get oxygen into our body and into our tissues and get the carbon dioxide out of our body. When we're looking at the respiratory system, we're looking at the following organs: the nose, the pharynx, the larynx, the trachea, the bronchi, and the lungs, or the alveoli and the lungs. The functions of the respiratory system: gas exchange between blood and the external environment, which occurs in the alveoli of the lungs, which I'll get to in a second. Your passageway in the lungs really are meant to help purify, humidify, and warm incoming air. It would probably be pretty uncomfortable for us if we were breathing really cold air. And also, we want to make sure that we're not getting any microorganisms or bacteria into our lungs. So, our passageways really help to sort of purify the air that's coming in and keep those negative bacteria or microorganisms out. Starting with the nose is really the only external part of the respiratory system that we can see. This is where air enters from the external part of the body to the internal part of the body. Um, the inside of the nose consists of a nasal cavity that's divided by a nasal septum. So if you look at your nose, um, where the two nostrils are, or the two nares, that cartilaginous piece between the two nostrils is what the septum is. Um, Going up a little bit further into the nose, we have the nasal cavity. This is where our olfactory receptors are. They're located in the mucosa and the superior surface of the nasal cavity. Our olfactory receptors, if you remember back to the nervous system, are our smell senses. Um, the rest of the nasal cavity is lined with respiratory mucosa that helps to moisten the air, again, as it's coming in, and to trap foreign particles in the nasal cavity so they don't get down into our lungs. The lateral walls of the nasal cavity have what we call concave, which are um, spiral shaped bones inside of the nasal cavity. And really, these are just meant to help increase the surface area inside the nasal cavity and sort of increase the turbulence from the air that's coming in. The nasal cavity sits superior to the oral cavity, so there needs to be some sort of separation, and that separation happens with the hard and the soft palate. We have what we call paranasal sinuses. Paranasal sinuses are the cavities that are in the bone that surround the nasal cavity. We talked about these a little bit when we were talking about the skeletal structure, when we looked at the skull. And the sinuses are located in the frontal bone, the sphenoid bone, the ethmoid bone, and the maxillary bone. And the paranasal sinuses really are there to help lighten your skull, considering it's sitting on our vertebrae. There's not much support there, so if our heads were too big, we probably wouldn't be able to hold them up. And they also act as a resonance chamber for speech. So if you were to plug your ears and talk, you would still be able to hear what you were saying. And it also helps to produce mucus that drains into the nasal cavity. These paranasal sinuses, when somebody gets a sinus infection, are what's filling up with mucus. Pharynx. Uh, so the pharynx is what we consider the throat, and it's just a muscular passage that goes from the nasal cavity down to the larynx. There's three parts of it. We talked about two of them when we talked about the digestive system, but the three regions are the nasopharynx, which is superior um, and behind the nasal cavity, the oropharynx, which is the middle sort of region, and then the laryngopharynx, which is the inferior region that attaches to the larynx. Um, the nasopharynx doesn't play any part in the digestive system, but the oropharynx and the laryngopharynx do. The pharyngotympanic tubes, these open to the naropharynx. These are the tubes that run from the ear down into the nasopharynx. Um, we have tonsils of the pharynx. We have the pharyngeal tonsils or the adenoids, which are located in the nasopharynx. We have the palatine tonsils that are located in the oropharynx, and the lingual tonsils, which are found at the base of the tongue. Larynx, which is what we call our voice box. Our larynx is there to help route air and food into the proper channels. If you remember back to the digestive system, um, the esophagus is where food goes into. And here in the respiratory system, we have our trachea, which I'll get to in a second. But our trachea is where air goes to, and our larynx helps to determine what needs to go where. The larynx, because it's the voice box, also plays a role in speech. And it's made up of 8 rigid hyaline cartilages that are sort of spoon shape. Um, and there's a flap of elastic cartilage connected to the larynx, which is what we call the epiglottis. Um, so the thyroid cartilage and the epiglottis are the two main structures of the larynx. The thyroid cartilage is the largest of the hyaline cartilages, and it protrudes anteriorly on the body. In men, we see this as the Adam's apple. It's not so prominent in women, so women don't usually have that sort of Adam's apple look to them. Our epiglottis is what helps to protect the superior opening of the larynx and is also what helps to route food to the esophagus and air towards the trachea. So when we swallow, the epiglottis really just moves up and forms a lid over the opening of the larynx, so air doesn't get, or the food doesn't get into the esophagus. We also have what we call vocal folds or vocal cords, what most people know them by. And these really just vibrate when air is expelled and helps to create speech or sound. Not to be confused with the epiglottis, we also have something called the glottis, which is the opening between the vocal cords. Onto the trachea, which is our windpipe. The trachea is about a 4-inch long tube that connects the larynx to the bronchi and the lungs. The walls are reinforced with C-shaped hyaline cartilage, and it's lined with ciliated mucosa. And this ciliated mucosa is there to help keep foreign objects or dust or debris or anything out of the lungs. And so the way that it works is that the cilia on the mucosa beat continuously, but they beat in the opposite direction of what the air is coming in. So as the air comes in, the particles get trapped in that ciliated mucosa, and then it gets expelled in mucus. So when we get sick, when there's microorganisms in there and we get congested when we're coughing, we're really just coughing up that mucus that has all of that debris and grossness in it. Here in this picture, you can see how the esophagus is in the posterior part of um, the throat area and the trachea is in the front. You can see the C-shaped hyaline cartilage. You can see the submucosa and the ciliated mucosa um, outlining the lumen of the trachea. Moving down, getting into closer to the lungs, we have what we call bronchi. And bronchi really is sort of a tree-like structure that goes from larger larger parts down to smaller parts. And they break off into sort of a tree-shaped structure. And when the trachea first comes down into the bronchi, we have what we call primary bronchi. And this is really the beginning of that tree. Um, and it enters the lungs at the hilum. Um, and the right bronchus is wider and shorter and straighter than the left bronchus. and the bronchi subdivide into smaller and smaller branches. Our lungs occupy most of the thoracic cavity. We also have the heart in there, but the heart is sort of in the central portion of the mediastinum between the lungs. Um, Unlike the heart, where the apex is at the inferior portion of the organ, the apex of the lungs are at the superior portion, and the base, which rests on the diaphragm, is at the inferior portion. Um, each lung is divided into into lobes by fissures. The left lung has two lobes, and the right lung has three lobes. Coverings of the lungs. The lungs are covered by what we call serosa. The serosa covers the outer surface of the lungs. Um, we have the pulmonary pleura that sits directly on the lung surface, and then we have something that we call the parietal pleura, which lines the walls of the thoracic cavity. And in between the pulmonary pleura and the parietal pleura, we have pleural fluid, which fills that area and sort of helps to cushion it. If we have, if you've ever heard of the term pleurisy, pleurisy is when there's inflammation in between these two linings. Um, Back to the bronchial tree division. Um, this is sort of the breakdown going from the largest to the smallest portions. We start off with the primary bronchi, we move down to the secondary bronchi, we move down to the tertiary bronchi, then to the bronchioles, then to the terminal bronchioles. Here you can see sort of the end where the terminal bronchioles end here to the right of the screen. Um, and then these bronchioles sort of break back down into the alveoli, which is where gas exchange happens in the lungs. Um, the respiratory zone, this is the area where the gas exchange really happens, and that is respiratory bronchioles, alveolar ducts, alveolar sacs, and then the alveoli. And gas exchange happens only in the alveoli. Our respiratory membrane, or the air-blood barrier, this is a thin squamous epithelial layer that lines the alveolar walls. Um, we have alveolar pores that connect neighboring air sacs, so the alveoli are able to connect to each other. The pulmonary capillaries cover the external surfaces of the alveoli, and these are the capillaries that helped with the gas exchange. On one side of the membrane is air, and on the other side of the membrane, blood flowing past. Uh, in terms of gas exchange, gas crosses the respiratory membrane by diffusion, which just means oxygen enters the blood from the alveoli and carbon dioxide enters the alveoli from the blood. At this site where the gas exchange happens, we do have what we call alveolar macrophages, which help to protect this sort of gas exchange by picking up any bacteria that may be in the alveoli. Four events during respiration. We have pulmonary ventilation, which basically is what we call breathing. It's just moving air in and out of the lungs. We then have external respiration, which is gas exchange between pulmonary blood and alveoli. Oxygen is loaded into the blood, and carbon dioxide is unloaded from the blood into the alveoli. Respiratory gas transport. This is when oxygen and carbon dioxide is transported via the bloodstream. And internal respiration is the gas exchange between the blood and the tissue cells in the systemic capillaries. So, as opposed to the gas exchange between the alveoli and the blood, internal respiration is the gas exchange between the blood and tissues. This is really where our body gets our sort of oxygen and fuel to continue to regenerate and function properly. Breathing is really a mechanical process that depends on volume changes in the thoracic cavity. And as volume changes in the thoracic cavity, it leads to pressure changes, which leads to flow of gases to equalize pressure. We always want sort of, again, we go back to homeostasis in the body. We want things to always be equalized. So when we're breathing, that's what's really happening. We're equalizing the gas exchange in the lungs and through the blood. Two phases of breathing: inspiration or inhalation, which is just flow of air into the lungs, and expiration or exhalation, which is air leaving the lungs. When we inspire, the diaphragm and the external intercostal muscles contract, the size of the thoracic cavity increases, and external air is able to come into the lungs because um, there's able to be an increase in intrapulmonary volume and a decrease in gas pressure. During expiration, muscles relax, air is pushed out of the lungs to a decrease in intrapulmonary volume and an increase in gas pressure. Forced expiration can occur by contracting internal intercostal muscles to depress the rib cage. This really happens when you're forcing air out of your lungs, though. Non-respiratory air movements, this can be caused by reflexes or voluntary actions. Some examples: coughing and sneezing, crying and laughing, hiccuping, yawning. As you can see, coughing and sneezing we do to clear our lungs of debris. Crying and laughing tends to be an emotionally induced mechanism. Hiccups and yawning are either sudden inspirations or very deep inspirations. Respiratory volumes and capacities. If we're normally breathing, a healthy individual should be moving about 500 milliliters of air with each breath that they take. And this respiratory volume is what we call tidal volume. There's many factors that affect respiratory capacity, such as a person's size, their sex, their age, their physical condition, how healthy or in shape they are, or how overweight they may be. Inspiratory reserve volume. This is the amount of air that can be taken in forcibly over the tidal volume. So basically, how much extra air you can pull in after a normal breath is taken. And usually this can be about 2,100 to 3,200 milliliters. Um, the expiratory reserve volume is sort of the opposite of the inspiratory reserve volume. It's the amount of air that you can forcibly exhale after a normal breath, and that is approximately 1,200 milliliters. Volume refers to the amount of air left in your lungs after expiration, because most people, when we're breathing normally, we don't exhale all of the air that's in there. So usually that's about 1,200 milliliters that's left. Vital capacity. Vital capacity is the total amount of exchangeable air, and so we get this number by adding the tidal volume, the inspiratory reserve volume, and the expiratory reserve volume together. Um, Dead space volume, this is the amount of air that remains in the conducting zone and never gets to the alveoli. It sort of just hangs out there and never gets all the way down to the gas exchange site. That's about 150 milliliters. Functional volume, that's the air that actually reaches the respiratory volume, which is about 350 milliliters. We usually measure respiratory capacities with something that we call a spirometer, which most primary care offices and hospitals would have. Respiratory sounds are sounds that are monitored with a stethoscope. Two recognizable sounds that we look for our bronchial sounds, which are produced by air rushing through the trachea and the bronchi, and then vesicular breathing sounds, which are soft sounds of air filling through the alveoli. Um, I will post a video on LMS that gives you an example of each of these sounds, as also abnormal breath sounds. External respiration, oxygen is loaded into the blood. Alveoli is always going to have more oxygen than the blood is because blood is moving carbon dioxide out and moving oxygen in, and we breathe into our lungs. Oxygen moves by diffusion across the membrane, and pulmonary capillary blood gains oxygen. That is unloaded out of the blood. Blood returns from tissues and has higher concentrations of carbon dioxide than air in the alveoli. Pulmonary capillary blood gives up carbon dioxide to be exhaled. Blood leaving the lungs is oxygen rich and carbon dioxide poor. Gas transport in the blood, oxygen transports in the blood. Oxygen just attaches to hemoglobin to form oxyhemoglobin. Um, and it transports through the blood via this hemoglobin. A small amount of oxygen is carried in the plasma, but mainly in the blood itself. Carbon dioxide transport is a little bit different. It's mostly transported in the plasma as a bicarbonate ion, which is HCO3. A small amount is carried inside the red blood cells on the hemoglobin, but at a different binding site than what oxygen would be attached to. Um, Carbon dioxide needs to diffuse out of blood into the alveoli, but because it's in bicarbonate form, it needs to be released from this bicarbonate form. And so basically, what happens is the bicarbonate ions enter the red blood cell. It combines with hydrogen ions. When it combines with the hydrogen ions, it forms carbonic acid, which is H2CO3. Carbonic acid splits off to form water and carbon dioxide, and then the carbon dioxide is able to diffuse from the blood into the alveoli. And then we're left with water. Internal respiration, this is just exchange of gases between blood and body cells. This is really where the oxygen is starting to feed the body. We're starting to see that oxygen is getting into the tissues that needs it. And again, without that oxygen, tissues would die off. Um, this is an opposite reaction of what occurs in the lungs, where carbon dioxide diffuses out of the tissue to blood, which we call loading, and then oxygen diffuses from blood into tissues, which is what we call unloading. Whereas at the respiratory zone, it is opposite. Neural regulation of respiration. Uh, the activity of the respiratory muscles is transmitted to and from the brain by the phrenic and the intercostal nerves. And the neural centers that control rate and depth are located in the medulla and the pons. The medulla in the brain sets basic rhythm of breathing and contains a pacemaker that um, is self-exciting for the inspiratory center. So the medulla sort of regulates how we take air in. And then the pons plays a part in smoothing out respiratory rates and making sure that um, we're not breathing too fast or too slow, or if we need to breathe faster or slower, the pons helps with that as well. Eupnea is what we call normal respiratory rate, and it's about 12 to 15 respirations per minute. Hyperpnea is an increased respiratory rate, often due to extra oxygen needs. So if the body is low on oxygen, we're going to breathe more to get more of that oxygen into our system. Non-neural factors influencing respiratory rate and depth. The physical factors are increased body temperature, exercise, talking, coughing, um, volition, which is conscious control. Volition is one of the reasons why when we're taking respiratory rates, we don't like to tell people that we're taking the rates. We try to do it without them realizing it because volition will, sort of comes into play and people start to breathe heavier or slower because they know they're being watched. And also emotional factors play a non-neural role in respiratory rate and depth. Chemical factors, CO2 levels in the body. The body needs to rid itself of carbon dioxide. So if there's too much carbon dioxide in the body, um, we're going to begin to start to breathe heavily because we're trying to blow off as much carbon dioxide as we can. So increased levels of carbon dioxide in the blood increases the rate and depth of breathing. Um, this normally happens when our blood becomes too acidic. Uh, in that case, we have too many hydrogen ions in our blood and carbon dioxide, and so we're trying to just get rid of the carbon dioxide all at once. As far as respiratory disorders go, chronic obstructive pulmonary disease or COPD. COPD, a lot of people think is a disorder in and of itself, but it's actually two disorders together, chronic bronchitis and emphysema. It's one of the major causes of death and disability in the United States. People who have COPD are almost always smokers or have a history of smoking. Labored breathing, which is dyspnea, becomes more progressive and more severe as time goes on. And coughing and frequent pulmonary infections are common with people who have COPD. Most people who have COPD become hypoxic. They retain carbon dioxide in their system, which makes them breathe more rapidly, and they have respiratory acidosis. Um, People who have COPD, especially if it goes untreated and unsupervised, will probably have respiratory failure as the disease progresses. Bronchitis. This is when the mucosa of the lower respiratory passages becomes severely inflamed. When this happens, mucus production increases, and mucus gets pooled in the alveoli or the area where the gas exchange happens. Um, if people have chronic bronchitis, it means that they have a higher risk of lung infection. Pneumonia is often a problem for them, and they tend to have a bluish tint to them, or what we call cyanosis. Emphysema. People with emphysema, their alveoli enlarge, and adjacent chambers tend to break through the alveoli. Um, Chronic lung inflammation helps to promote lung fibrosis, which is hardening of the lungs, or scar tissue of the lungs. Airways tend to collapse during expiration. Patients use a large amount of energy to exhale. Overinflation of the lungs leads to a permanently expanded chest, which is what we call a barrel chest. Somebody has this, we need to measure the barrel chestedness, the circumference of it, to make sure that we're keeping an eye on how big the barrel chest is actually getting. Um, and because cyanosis that bluing that we talked about before appears late in with emphysema, they tend to have more of a pink tint to their skin. Lung cancer accounts for 1/3 of all cancer deaths in the United States. It's The incidence of lung cancer is greatly increased with people who smoke or have a history of smoking. And the three most common types of lung cancer are squamous cell carcinoma, adenocarcinoma, and small cell carcinoma. You can see um, relatively healthy lung on the right and cancerous lung of a smoker on the left. During development, lungs are filled with fluid in the fetus. Lungs aren't fully inflated with air until about 2 weeks after birth. Um, Surfactant, which is a fatty molecule made by alveolar cells, lowers alveolar surface tension so that lungs don't collapse between breaths. And it's not present until late in the fetal development and may not be present in premature babies because we see this developing around 28 to 30 weeks of pregnancy. Any babies that might deliver before that probably won't have this surfactant. Homeostatic imbalance in development, infant respiratory distress syndrome. This is when that surfactant doesn't produce or is adequately produced, which can cause to lung collapse. Cystic fibrosis is an oversecretion of thick mucus that clogs the respiratory system and makes it difficult for that gas exchange to happen. Respiratory rate changes throughout life. Um, Adults, 12 to 18 respirations per minute is normal, but for newborns, 40 to 80 respirations per minute is normal. So, as you can see in this list, infants, 30 respirations, age 5 or more to adulthood, 25 respirations. Um, Rates are going to increase somewhat as we get older because that gas exchange isn't as effective as it once was. And so our body needs to get more oxygen in. Sudden infant death syndrome or SIDS. This happens in healthy infants usually. And what happens is they stop breathing and they die during sleep. Um, Some cases have been known to be neurorespiratory control center issues. About a third of them seem to be due to heart rate rhythm abnormalities. And some recent research is showing that there's a genetic component to this. Uh, the issue with SIDS is that because it happens in healthy infants, there's not really any precursor that most people notice before it happens. Asthma is a chronic inflamed hypersensitive bronchial passages, and people who have asthma tend to have a lot of dyspnea, cough a lot, wheeze a lot, and really this is just a response to sort of any irritants that are getting in there and making this hypersensitivity even worse. As we age, lungs become less elastic and aren't able to expand as much. Vital capacity decreases, blood oxygen levels decrease, um, stimulating effects of carbon dioxide decrease. Elderly are known to be hypoxic or exhibit sleep apnea. They tend to have a more difficult time breathing while they're sleeping, and they have a much higher risk of respiratory tract infections.